We will move on to our next session. At the 2018 annual meeting, we debuted the top educational content, or TEC Talks. And the 4 TEC topics and speakers are chosen by the Professional Development Committee to address the most important current practice gaps faced by pediatric surgeons. I'd like to invite Dr. Rob Ricca to the stage, who will introduce our first TEC speaker. Dr. Ricca is an associate professor of surgery at the University of South Carolina.
I thought I was off the hook.
I'm introducing you.
I was hopeful. You did a great job. Thank you. All right. That's perfect. Thanks. Good afternoon, everybody. On behalf of the Professional Development Committee, it truly is a pleasure for me to be able to introduce our first speaker for our top educational content talks this year. Our committee is really excited about the 4 speakers and the 4 topics that we have chosen for this year. Our first topic is one that we all see clinically, the management of, as you see, perianal disease in the infants. What do we do with the child with the fistula and ano? What do we do with the child with the abscess? Here to present that information is Dr. Shannon Acker, Associate Professor at the Children's Hospital of Colorado. She's integrally involved in a systematic review that the Outcomes Committee, our own Outcomes Committee, is working on currently. She's one of the lead authors to look at this common clinical condition. So, Dr. Acker, thanks for coming today and providing us with an update on this important clinical information. Thank you.
Well, thank you, Dr. Ricca, and to the program committee. I am hopeful that everyone here is as excited to talk about infant perianal disease as I am. I have nothing to disclose. I'll try to limit the number of pictures of perianal abscesses as we go through this. So as Dr. Ricca mentioned, this is a common problem that we all see. Perianal abscess and fistula and ano occurs in about 0.5 to 4% of all infants. The vast majority of affected infants are male, and they usually are pretty healthy. They present without signs of systemic sepsis or systemic infection. And these abscesses can actually drain spontaneously and resolve spontaneously in some cases, even if we don't do anything. The fistula can usually be treated with a simple fistulotomy, and the reason for this is a picture that hopefully doesn't give people too much PTSD from residency with all the intersphincteric and transsphincteric fistula, but in infants with fistula and ano, it's usually these superficial fistula. And so a fistulotomy is usually safe and doesn't carry a huge risk of future incontinence. And so we as pediatric surgeons have a therapeutic dilemma because we don't actually know what the best treatment strategy for these infants is. So we can recommend hygiene, sitz baths, and keeping the area clean. Sometimes we'll recommend hygiene plus antibiotics. Some of us would recommend taking the patient to the OR, doing it in the clinic, and aspirating the pus with a needle. And then some people would just take the baby to the OR. So there's a couple questions embedded in here. So if you open up your app and click on the polling questions, if you find this session, there's 2 questions. They're actually the same question. So the intention is to answer it now and then answer it again at the end after we review the data. So if you pull up the first question, it's an 8-month-old previously healthy male with a 1-day history of a painful lump and an ultrasound that shows a 2.8 centimeter complex fluid collection surrounding hyperemia consistent with an abscess. So what would you recommend to the family if you saw them in the emergency department? The options are hygiene plus antibiotics, needle aspiration, or incision and drainage. So if everybody wants to vote, we'll pull up the results in just a minute, but give a little bit more background. So as Dr. Ricca mentioned, the Outcomes and Evidence-Based Practice Committee was charged with conducting a systematic review of the literature to evaluate current management and expected course in infants with perianal abscess and fistula and ano. And so we asked the following questions. Number 1 was, what's the best management strategy for infants with perianal abscess? And we measured that by what's the rate of failure of initial management, what's the time course for expected complete resolution, how many children will go on to develop a fistula and ano, and then what's the expected resource utilization of our recommended treatment strategies. And the second question is, what's the best management for fistula and ano of these infants? So we divided this up into 3 different management strategies. We grouped non-operative management together with needle aspiration. The second management strategy was incision and drainage with or without a drain placement, and then finally fistulotomy. So I was going to pull up the polling questions. Let's see, so 222 responses. It looks like about a little bit, maybe a third, recommend incision and drainage, and then the next most common answer was hygiene plus antibiotics. So 99 of 230 recommended IND, 73 of 231 recommend hygiene plus antibiotics. So we'll see if that changes as we go through here. So looking at the literature for non-operative management, including aspiration, there were 12 studies. As with most pediatric surgical systematic reviews, these are predominantly single-center retrospective reviews. There are a total of 1,681 infants and children with perianal abscess, about half of whom were managed non-operatively. So what does non-operative management entail when we say this? So it always includes hygiene and sitz baths. In one series, they did hygiene sitz baths plus a topical antibiotic on top of the abscess. Next most common was hygiene sitz baths and systemic antibiotics. One group recommended the parents take the baby home and apply gentle pressure to the abscess to see if they could get it to drain on its own. One group, if the abscess was not draining spontaneously, they would do a needle aspiration. And there are a few reports of an oral TJ122. This is a traditional Japanese medicine that's used to treat perianal abscess. And then one series where they applied topical basic fibroblastic growth factor spray directly on the abscess as the treatment. So looking at these data, what's the failure rate of initial non-operative management? So this was reported from 5 studies, and it was a total of 54 of the 135 patients, or a 40% failure rate. That rate was a little bit lower with this oral medication, but the oral medication was administered for about a month. And then, if you see a baby in the emergency department and you tell the parents, okay, we recommend antibiotics plus keeping the area clean and soaking the area, and the next question they're going to ask you is, okay, well, when is this going to get better? So this number was reported in 7 studies. With hygiene sitz baths and antibiotics, the median time to resolution is about 5 to 10 days, but there's at least one series that reported a median time of 28 days for that abscess to resolve with non-operative management. So then looking at non-operative management, what's the rate of recurrence? So this was reported in 7 studies. In these individual studies, it ranged from about 3 to 55%. If you combine the data, 147 of 700 patients, or 21%, recurred. The time to recurrence was reported as a median of 1 to 7 months after that initial abscess. And then importantly, how many babies are going to go on to develop a fistula in anal? This was reported in 6 studies. A total of 55 of 278 patients, or 20%, developed a fistula a median of 4 months after the initial abscess. So the next management strategy was incision and drainage. So 20 studies reported on IND without a drain placement or fistulotomy performed. 1,000 patients had an IND. 224 developed a recurrent abscess, so about a quarter of them. And then 194, or 13.7%, went on to develop a fistula in anal. So the numbers really are not different for non-operative management and IND. There was one series that reported on routine drain placement after incision and drainage with a 40% recurrence rate, so probably not better than IND alone. And then what's the time frame for expected resolution and recurrence after incision and drainage? The largest study reported on 300 infants, about 25% recurrent abscess or fistula in anal at a median of 18 days after the initial therapy. In a lot of these studies, the recurrence and the fistula development were combined as a single outcome, so it's a little difficult to tease out the difference between the two. But these authors identified kind of 2 distinct groups of patients. About half of the patients they considered fast responders that underwent IND, completely healed within about 3 weeks. The other half of the babies they put in this slow responder group. These are the ones who developed a recurrent abscess or a fistula. About a quarter were completely resolved within a month, 70% by 6 months. And of the patients who went on to develop a fistula, only half of them were completely resolved within a year. And the time to recurrence was very widely variable between the studies, so hard to make anything out of that. And then the final management strategy was fistulotomy for fistula and anosis. The data were reported from 8 series, 289 patients. There are different management strategies for these fistulas. 18 babies managed non-operatively, 48 with a cutting seton, 33 with a non-cutting seton, and then fistulotomy performed in 190. And so the rate of recurrence was reported at between 0 and 15% for infants that had a fistula managed. The recurrence rate, if you combine those, it was 20 of 289 patients, or about 7%. The time to recurrence was a median of 46 days. In the one study it was reported, all the recurrences occurred within 9 months of initial management. The time to complete resolution after fistulotomy is about 3 to 6 weeks. That makes sense for how long it takes for the wound to epithelialize and heal. If you use a cutting seton, obviously it took a lot longer, 4 to 28 weeks. And then importantly, in this series of 289 patients, there were no patients with fecal incontinence that was reported within the follow-up period of these studies, which ranged from 46 days to 6.5 years. So this table is meant to summarize the data. So for non-operative management, the failure of that initial management was 40%. The rate of recurrence for non-operative management, incision and drainage was about the same, 21% or 24%. Fistulotomy was lower at 7%, but that's a little bit different disease process. And then what's the rate of fistula development? 20% in the non-operative management group, 14% in the IND group, and then time to resolution was about the same in all the strategies. So back to the initial polling question, if you pull up the second one, interested to see if anybody's opinion changed. So again, 8-month-old previously healthy male, 1-day history of a painful lump, ultrasound consistent with an abscess. Who would recommend hygiene? Who would recommend hygiene and antibiotics? Who would recommend needle aspiration? And the final strategy was IND. So while you guys answer that, I just wanted to thank the team who reviewed all the data and helped put all these data together for us today. And I'll pull up the polling results. So it looks about the same. So nobody changed their mind. So now we've got 50, maybe a little lower in the hygiene and antibiotics group. It was 53 of 187. I think the first time around it was like 70 of 187. And then IND is about 100 out of 187 responses. So maybe a little bit more in the IND group, a little bit less in the hygiene and antibiotics group. Perfect. Thank you.
We have some time for questions. Any questions? Do we have time for questions? Maybe 1 minute. Do we have any questions? Yeah. Yeah, sure.
Tony Escobar from Mary Bridge. Does everyone use ultrasounds for perianal abscesses?
Often the ultrasound is done before we hear about the patient.
And with a negative ultrasound and the kid is ready to pop is what I've found, but thank you. Thank you.
Thanks. Perfect.
Thanks.